Okay, we're going to talk about the significance of trunk extension in orthopedic development. Postural control. What is postural control? It's the ability to keep a posture or hold the upright position while moving and engaging in all kinds of tasks. It basically means you can stay upright and do something at the same time. Postural control begins in the drive for verticality. This drive to get upright begins at birth. It's innate, and it seems to be life-preserving. It's a very low-level brain function. The drive to get upright fosters antigravity muscle action in the extensors of the neck and trunk, and then the flexors of the neck and trunk. This ability to come up against gravity progresses from head to toe, and from the trunk out to the extremities. Antigravity riding reactions are direction-specific postural patterns executed by the whole body. They're muscle activations on the side opposite any body sway that maintain verticality, or the upright position. Babies gain postural control in a sequence over many hours spent in play in each developmental play posture, and each one of them marked by variability of movements and limb functions, such that babies don't really operate like machines. All the movements that a baby engages in engage the sensory receptors. Full-term newborn lower limb alignment and a healthy nervous system support the infant's acquisition of postural control. The first ingredient and most essential foundation for postural control acquisition is extension against gravity, bilateral and symmetrical muscle action that brings the head and trunk up against gravity. Antigravity extensions evident in babies as young as 3 months of age who raise their head and activate the upper trunk, and older babies who raise the entire head, trunk, and limbs against gravity in ventral suspension. By 6 months, most children will show you that they can extend against gravity with a full push-up onto both hands. The achievement of anti-gravity extension can be a fundamental shortfall in orthopedic development in children with cerebral palsy. Here we see a premature child of 21 months of age in ventral suspension who doesn't show extension against gravity with her head, neck, or trunk. Lying on her belly in the prone position, her spine looks much like that of a newborn child. The 11-month-old baby on the right is having difficulty firing both extensors against gravity symmetrically. The second ingredient for postural control acquisition is anti-gravity flexion. Flexion is actually built upon the foundation of extension, and again it's bilateral and symmetrical. The 4-month-old shows achievement of anti-gravity flexion and an ability to hold a back-lying posture with arms and limbs in the air, all symmetrical, and with the trunk in a rectangular position, shoulders and pelvis parallel to each other, with use of all the limbs symmetrically. Later, 6 months or so, the same child should be able to bring the foot up to the face and chew on his own toes if he wants to. All of this is the anti-gravity flexion capability. Children with diplegia often show a shortfall of anti-gravity flexion. Baby on the left, who's 4 months of age, is lacking not only symmetry through the trunk, but the flexion of the limbs against gravity. The 6-month-old child is showing an extension of the limbs rather than flexion. And the 20-month-old child is still showing extension of the limbs while trying to play in supine. These look like efforts to stabilize, where the trunk is inadequate to do so. These extension postures make it look as though the child is stabilizing with his limbs because his trunk isn't able to offer the same postural control. When a baby achieves extension and flexion against gravity, he can move on to early lateral weight shifts. In a skull side shift, a baby is able to offload the arm on the face side so he can reach for something. The skull side weight shift brings flexion in on extension. Unloading the face side limbs produces movement. This will lead to rolling and reaching and belly crawling. Usually occurs about 5 to 6 months of age. The diplegic boy down below is showing an inability to execute a competent skull side weight shift, with the result that he drags himself on the floor rather than offload his limbs on the face side to belly crawl. And again, you see him using extension in his legs as an effort to stabilize his body. When babies have extension and flexion against gravity, they can eventually sit by themselves with legs in kind of a frog leg posture. Hips are abducted and the knees flexed. And a unique characteristic of the normal infant sitting is that the spine is absolutely straight. The sacrum is vertical and the spine is vertical above it, and the head is located above the spine. This is ideal for bringing in anti-gravity flexion, which always follows extension. The baby who sits up straight might lean backward a little, and with that will activate his abdominals. Once extension and flexion are acquired, these babies can shift their weight to the side to side. And once they can shift their weight side to side, they can rotate. And with this rotation comes movement transitions or postural transitions between sitting and all fours back to sitting. Most children with cerebral palsy have difficulty in maintaining a sitting position, primarily because they lack the anti-gravity extension through the trunk and neck that was the foundation for building anti-gravity flexion. So you see these children engaging their limbs in balancing, either by holding on to the floor or locking the elbows between the knees, bringing the shoulders forward, or for the child in the middle, W sitting, which is very stable place to put the limbs to sit, but it doesn't lead to any movement or lateral weight shifts, or just propping on hands too much. So we're going to suggest that lower limb muscle extensibility, meaning how loose the muscles are, the range of motion you can see in the lower legs, shows evidence of routine use. If the legs are not used for balancing all day, they'll be loose. So there'll be evidence of postural control status and the resting play postures baby's been using, the movement strategies the baby uses, and the physiologic adaptation of the muscles, soft tissues, nerves, and other tissues to routine use. Ideal limb muscle extensibility demonstrates a first catch. We call that R1. R1 emerges in normal development in the lower extremity muscles that have to do a lot of work. So it takes years for the R1 or the first catch phenomenon to be seen. So here with ankle dorsiflexion, a child about age 3, if the therapist were to dorsiflex his ankle, would run into a resistance. That's called a catch. And that resistance occurs in dorsiflexion, probably 10 or 15 degrees. And then there's more extensibility after that, up to 25 to 30 degrees. So these are normal ranges for a child this age. Hip abduction range of motion can be 40 degrees before we hit first catch. This is true of preschoolers and should be true of all of us. Hip extension range of motion after age 8 years ought to be at least 8 degrees, 10 degrees before hitting first catch in the prone position. This extensibility takes 8 years to acquire. A competent trunk is the base of operations for effective use of the limbs and for effective movement. When trunk control is compromised, postural control efforts are shifted to the limbs, where they're used tonically to hold upright postures. If the limbs are engaged in maintaining upright postures, if they're stabilizing all day, they can develop contractures. This is common in children with pyramidal type cerebral palsy. So the hypothesis I'm proposing here is that lower extremity muscles recruited tonically to maintain upright postures eventually shorten. These include muscles like the gastrocnemius, the calf muscle, the iliopsoas and rectus femoris, which are hip flexors, the hip adductors, the ones inside the thighs, and the hamstring muscles. The segmental assessment of trunk control is a procedure that's been developed by Penelope Butler and others in the United Kingdom. It's a method for quantifying trunk control against gravity, segmentally. So how can we optimize trunk and pelvic alignment? So we can optimize the weight distribution that's taken through the spine and the pelvis, to optimize the sensory input that the child experiences, so we can optimize the responses, the postural responses to weight shifts and displacements, so we can optimize limb muscle use and strength. We're going to try shifting the focus of management off of the symptoms of postural control deficit, which is seen in limb muscle contractures, and onto a significant source. We're going to try to stop repeatedly weakening stiff limb muscles and instead work to align and strengthen the core. One method of improving outcomes for kids with cerebral palsy would be earlier referral. If we could see children at 4 months of age who haven't yet achieved the symmetrical bilateral anti-gravity extension in prone and flexion and supine that we hope to see, we urge physicians to refer these children for close follow-up by trained physical therapists. We're also going to need to foster massed practice of effective anti-gravity trunk flexion and extension. We're going to do this by optimizing sensory input and anti-gravity muscle use in typical play postures. Babies will develop extension and flexion in the sagittal plane first, which is front to back, then the frontal plane, side to side, and finally the transverse plane, which is rotation. We hope to institute postural control strategy changes so the children who are depending on their limbs to stabilize and balance will learn instead to depend on their trunk muscles so their limbs can relax and function. We're going to use biomechanical assists. Where it's necessary to help with sitting, we might insert a wedge under the pelvis to tip the pelvis forward. This can happen all day long in all the seats the child uses. Or we'll bring the heavy head and upper trunk into a more vertical position with the assistance of TherAlign onesie here with a V-strap so that the work against gravity is minimized and the effective function against gravity is optimized. There's somatosensory strategies. Manually loading the pelvis, for instance, to help a child find his way to raising his head and trunk. Loading the pelvis acts like an anchor and delivers a lot of somatosensory input that the child can use to respond to raise his head and upper trunk. Then there's kinesiotaping, which adds somatosensory input and some tactile cues for muscle function. There's TherAlign with strapping, adding a big somatosensory dose to the whole trunk, plus strapping to assist the long underused muscles to function in a shorter state. putting high-friction materials in slippery surfaces like Dyson on the seat of a high chair. Kinesiologic strategies have to do with shortening functioning long muscles and helping the child to use them in shortened state. Here, Willow is aged 10 months, and she's not showing us the straight baby back. We don't see the vertical sacrum or the vertical spine. So she's not recruiting her abdominals effectively. Here she's wearing a onesie with a new V-strap. It's got a trunk extension assist, a characteristic of vertical fabric being stiff, and it's attached from the shoulders to the pelvis. And with a better back extension, when she rocks backward, she can bring in her abdominals against gravity and build her core. One of the slogans for neurodevelopmental treatment that I learned long ago is proximal stability comes before distal mobility. In this way, therapists work to bring on co-activation of the trunk muscles, knowing that they operate as a foundation for movement. Arndt and others did a study where they compared the effects on movement acquisition of providing a sequenced and dynamic trunk co-activation program to the effects of a parent-infant playgroup management protocol. And only the group that received the neurodevelopmental treatment with sequenced dynamic trunk co-activation exercises showed significant change in their gross motor function measure scores over time. This means that they changed their movement skills. So, unlike working on trunk stability to get trunk stability, they worked on trunk stability and gained movement skills. So, looking for orthotic assistance for this effort to improve trunk control and particularly trunk alignment, if you look at rigid thoracolumbar orthoses for children, they're generally used for scoliosis management or spina bifida and spinal muscular atrophy and spinal cord injury and severe cerebral palsy with spinal malalignments. And they're basically replacing muscles rather than assisting them. Many of these children, the trunk musculature is defective anyway. So we don't generally consider these TLSOs, which are thoracolumbo-sacral orthoses, as biomechanical aids to achieving postural control. We tend to think of them as compensatory aids to achieving sitting. A newer development in orthotic design is a semi-rigid backpack-style trunk orthosis. Studied in Germany, 62 women who were more than 50 years of age who had osteoporosis, pain, and kyphosis angles greater than 60 degrees wore a SpinoMed orthosis, which is slightly flexible and doesn't package the entire trunk in a hard container. It does offer an abdominal support, a little shoulder retraction, and assistance for spinal alignment. These women wore the SpinoMed for a minimum of 2 hours a day for 6 months, and the researchers were able to test their muscle strength in the trunk. On average, they showed a 73% increase in isometric back extension strength and a 58% increase in abdominal flexor strength. These are enormous gains, and they're secondary to achieving an improved functional alignment. They also showed an 11% decrease in their angle of kyphosis and a 25% decrease in body sway, which is evidence of improved postural control. In a study undertaken by Curtis and Butler and others in 2015, comparing scores of the segmental assessment of trunk control to gross motor function measures and the Pediatric Evaluation of Disability Inventory, the study supported the hypothesis that segmental level of trunk control is one of the most important factors determining gross motor function and mobility skills for children with cerebral palsy. These authors suggest that it would seem possible from this study that increasing the segmental level of trunk control through training or bracing the area of the trunk where control is weak could produce clinically significant improvements in gross motor function and mobility. They suggest this is true for all aspects of trunk and postural control that are static, active, and reactive. Penelope Butler's also been developing an approach to treatment called targeted training. In targeted training, the therapist reduces the degrees of freedom below the site she or he is working on to gain control. So this would be perhaps packaging the trunk in order to build head control, and then letting go of the upper trunk to build upper trunk and head control, and moving segmentally down the spine. It was actually through targeted training that Butler developed the segmental assessment of trunk control. There are several studies that support targeted training and that relate segmental trunk control to functional skills. So what can we offer that implements the evidence pertaining to postural control? Well, TherAlign has developed a Dragonfly TLSO system. Named the Dragonfly only because it vaguely resembles one when it's flat and before it's heated. It's a warm and form device that the orthotist can easily mold with comfortable contours to capture the child's pelvic crests, providing a stable support base for aligning the spine. The Dragonfly TLSO system includes a TherAlign posture and torso alignment subsystem, so it comes with garments and strapping. The Dragonfly TLSO system is unique in this way because the subsystem provides a cozy body hug that delivers sensory input and raises body awareness and adds hip stability. This garment system also delivers a Velcro-sensitive surface for attaching muscle-assisting straps. And it can be used for ongoing intervention when the TLSO is not in use. The Dragonfly has been verified by Pediatric for TLSO billing code L0456. So why do we go there? Why develop the Dragonfly? Because we often need more trunk extension assist than the TherAlign strapping can deliver. And since trunk extension is so important, if it's difficult to obtain, the strapping can be too complicated for caregivers to manage. You can also use the Dragonfly in targeted training because it reduces degrees of freedom in the trunk, so you can promote postural control acquisition above it. Here you see a child who's been using the Dragonfly together with a neck collar for 15 days. Without it, 4 hands are required to manage her trunk and head. With it, the therapist can handle her effectively. And she's already able to sit on her own for 20 or more seconds wearing the Dragonfly, while she has zero ability for upright stability without it on. Who should use the Dragonfly system? Any candidate for TherAligns with a flexible kyphosis or lordosis that can be manually corrected without force. Children who show a flexible lateral curve of the spine are also candidates, but if they have idiopathic progressive scoliosis with rotary components, we consider them contraindicated. The Dragonfly TLSO is custom fitted by heating it at 160 degrees Fahrenheit for approximately 10 minutes to soften it thoroughly. It can be heated in a standard oven or in a variety of other ways. Hydrocollator inside a plastic bag, or on a warming tray for the smaller sizes. The garments are donned first, and the clinician would rehearse the molding of the Dragonfly, and then arrange a distraction, something to do for the child to keep his attention elsewhere. And the warmed Dragonfly, which is flexible, would be laid on the child's trunk and strapped into position. Then the clinician molds the shoulder straps, forms the pelvic crests, contours the lumbar spine interlordosis, and can accelerate the setting with a cold, damp cloth. When it's set up, it's removed, and the apron and strapping are sized and attached. The subsystem can be used to do things that a standard TLSO cannot do. Strapping can be used to stabilize the scapula, for instance, against winging, or against excessive migration with arm movements, or to reduce shoulder protraction or retraction. Strapping can be used to shorten and assist the lower transverse abdominal muscle, or to shorten and assist the hip extensors and lateral rotators. We advocate for team planning to optimize the wearer's satisfaction and outcomes. And of course, the parents and the child are team members. We have ideas for researchers of the TLSO as a live-in training aid to acquire postural control and trunk muscle strength and movement skills. For instance, how does some period of wear for a certain schedule influence the SATCO score, or the trunk impairment scale, or the resting kyphosis angle in sitting and standing, or the magnitude of body sway in sitting or standing while engaged in a task. The Wii balance board can be used for this. How does it influence motor skills, the gross motor function measure, the quality of function measure, or the percentiles of the gross motor function measure? What about vital capacity? How does that improve? Here's a method for quantifying sitting resting postures. You can do this with your cell phone camera. If our ideal is to expect a straight sacrum and a straight spine after the age of 6 months in the sitting position, then you can take photographs of your client from the lateral point of view in sitting position. Look for the most lateral viewpoint and start a line from cervical 7 and draw it down the spine as far as it'll go. Begin another line along the sacrum and draw it up the spine as far as it will go. If those lines intersect to form an angle of any number, then you have a problem that needs remedying. You also have a quantity. So progress would be any reduction in this angle of intersection of the two reference axes that you drew on the spine. To summarize, head and trunk control precede limb use and movement skills. Proximal stability precedes distal limb mobility. Functioning alignment influences muscle recruitment, muscle strength, and muscle length. All the neuromusculoskeletal tissues adapt to a routine use history. Postural control is acquired through massed practice. Optimizing functioning postural alignment might require modifying the base of support. Find more ways to optimize routine postures and functional strategies. A semi-rigid backpack type TLSO can be used to support the goals of improving trunk muscle balance and strength, improving postural control or balance, and preventing and reducing limb muscle contractures that develop with compensatory stabilizing recruitment of the limb muscles. Thank you for this honor and for your interest, time, and attention today. For more information, contact TherAlign.com.